everyone. I'm Leslie Cornwell, Certified Nurse Midwife with Midwifery Business Consultation. This next section has to do with legal defense tips for midwives. A legal disclaimer we put at the beginning of all of our presentations. This information is for general and educational purposes only, not intended to substitute for professional, legal, or clinical advice. We strive to keep our information as accurate as possible, but make no claims, guarantees of the adequacy, and expressly disclaim for liabilities and errors. Objectives: the students will be able to verbalize why legal defense tips are important for midwives. The students will be able to verbalize ways midwives can be sued. The students will be able to verbalize the different ways to reduce the risk with proper documentation, policies, protocols, training methods for your team. The student will be able to verbalize examples of different situations where healthcare providers were sued so we can learn and grow from. So defending yourself through documentation is really important. You want to clearly put in writing what was discussed, what you had done, what was the thought process, and the follow-up plan. In nursing, it's very clear. We always hear if you didn't chart it, you didn't do it. And in midwifery, depending on the training and your apprenticeship model and the school you went to, sometimes there's not as much stress on the value of documentation. It has multiple purposes. It's used to continue care, collaborate, transfer, make sure that everybody's on the same page of the management plan, but it also is a legal defense tool for you in many states up to 18 to 21 years in obstetrics. And so it's really, really important. You're not going to remember years later the situation, the scenario. You want your documentation to tell a story. You want it to talk clearly that the family made this decision, you gave them all the resources, they signed the consent, they talked about all the options. You didn't know, you had no hindsight about a risk factor and assessment piece. You based your decision on the information you had at that time, and so it's really important in medical emergencies and situations and things that you could be sued for to really show your clinical decision making, the options, the interventions, and did it improve, did it not improve? The follow-up, I don't see that a lot in midwifery charting. Is they put the intervention they did, but did it improve the situation? Did it make it worse? The follow-up communication of did that intervention, reassessment help or not help? So be precise about things you take for granted. Assessing, how do you know a baby is normal, healthy baby? They're alert, there's good muscle tone, there's pink. You need to overstress the obvious. There's so many things that are just subconsciously done by midwives in the assessment that we don't put in our notes. We don't even talk about because they're reassuring signs of normal and we're like, duh, this is normal. But you need to put them in writing that you're thinking about them. This is normal bleeding. She's got normal bloody show. There's no leaking of fluid. When you checked her cervix, the baby was head down. Leopold's, like, what are these obvious things that are normal that you just tend to not chart because you don't think they're a big deal? You want to be very, very thorough of not just the deviations of normal, but also the normal assessment pieces that you are consciously and subconsciously looking at all the time. So never pre-chart. This tends to be an issue more in the EHR, the medical world. If you're going to see people in the office the next day, you could be copying and pasting notes from their last chart. You're trying to get started in the morning. We really strongly encourage to chart in real time as things are happening, because sometimes if you copy and paste templates, you try to chart ahead of time, the person doesn't show up, that's not really the assessment. You accidentally forget to remove something. So an example that's given here is a CNA pre-charts on her work. She's planning on seeing somebody, taking care of them later in the day, and this is, she always at noon, she always at 1 o'clock does XYZ, and then the person dies before noon, and that's in the chart. It's really hard to show up your credibility and your strength when you're actually charting things that aren't happening because you were trying to be proactive, and then things got busy or they passed away and it got put in the chart. So especially if there's copy and pasting of prenatal visits from EHR systems, they're like, is she really exactly the same every single time? It starts to question your credibility of your charting. So report all the issues, complaints, normal things, educational topics, everything you're doing. Make it tell a story. If you spend 15 minutes with them in a prenatal visit, you spend 60 minutes, you spend time breastfeeding, you spend time educating about VBAC options, they signed a consent, they consulted the OB, you talk to them on the phone, like everything you're doing to help the families make the best decisions, and you're assessing them, you're thoroughly asking about history, you're thoroughly reviewing labs, results, you've talked about their 20-week anatomy scan, everything was normal, there's a low-lying placenta, you're following up with it. What are you doing about these concerns, about these things that are coming up? Never underestimate the power of a patient complaint. Whether you think it's not a big deal, it's just they're worried, they're anxious, you always want to chart it. Patient is concerned about decreased fetal movement. Well, what are you doing about it? You reviewed fetal kick counts, you did a good thorough assessment, there's no leaking of blood, there's no leaking of fluid, there's no discharge changes, there's no cramping. You do a non-stress test if they're after 32 weeks gestation. It was reassuring, it was not reassuring. You ordered an ultrasound to do a biophysical profile. You're doing the appropriate steps based on the concern and their unique specific history. So we have a lot as midwives we have to think about, we have to determine, is this independently part of our scope? Is it something I need to collaborate with a physician? Is this something I need to transfer based on the setting I'm serving plus my scope of practice? So anytime there's a concern, there's a complaint, there's an abnormal assessment piece, what are you doing to follow up on it? And maybe it's just monitoring. Maybe the blood pressure was elevated and you want to determine, is it pain from a contraction? You're going to repeat it in 15-30 minutes. Sometimes it's just a simple reassessment in a little bit later time. So another thing that could be an example is, say you have a C-section lady, a post-op, she ended up with a transfer, she didn't get the birth she wanted, she's now in your clinic, it's 2 weeks postpartum, it's 6 weeks postpartum, she's having some mild abdominal pain, but all her results, her test, her assessment is minor, negative. You, based on your assessment, didn't see anything obvious. Do you decide, you don't know exactly what's causing her pain and her discomfort? Maybe it's the incision site, maybe there's some underlying issue. Anytime there's a C-section, anytime there's a surgery, we didn't directly do the surgery as a midwife. We should be chatting with the doctor, be like, hey, I did this assessment, her tests are good, her assessment is good, there's maybe a right lower quadrant pain, super tender site. You need to follow up. Maybe you need to do an ultrasound, you need to do a CAT scan, you need to have a conversation with the OB anytime it's outside of our service. We didn't provide the C-section, so we need to have a conversation, especially those postpartum ladies, because you don't know at the moment, is there that rare perforation of the bowel? Is there some rare incisional site is opening that you can't see based on your assessment? And so you want to look at the complaint and how did you adequately follow up with it? Is it needing reassurance, or is there something serious more going on? Because there's a lot of complications with surgeries we may or may not understand as midwives. So you always want to double check that everything is charted correctly, especially when you're tired and you're exhausted. If there's high risk situations, you're taking care of the VBAC, or in the hospital setting, you're giving pain medicine, you're giving IV Phenergan, Stadol, Nubane, morphine, you're giving an epidural. You want to make sure the orders you're putting in are accurate. You want to make sure that if you're in the community-based setting and you're providing Nubane, Stadol in your birth center, you want to make sure that you've double checked, you've triple checked the dosage, the amount you drew up in the syringe, the allergies, any risk factors that they contraindicate them getting that medication. You really want to be thorough. That we don't have as much in the midwife world of wrong patient, because we usually are in a community-based setting. But if you're in a labor and delivery unit and you're helping out, particularly the nurses, they need to make sure that they're giving the right med to the right patient in the right order. So there's some check and balance systems. But you want to make sure that everything is double checked, triple checked, especially when it's high risk medications that can have a lot of risk with overdose and incompatibility for mom and for baby. We're responsible for 2 people when we're doing labor management, when we're serving them and supporting them prenatally, that we've got to be super careful in our decision making and medications we're recommending. If we recommend Ambien, if they should have an induction in the hospital based on medical risk, we got to be very thorough in a discussion with their families, the risk and benefits, the choices, the decision they made. You want to put in documentation anybody you talk to. If you talk to a colleague, you're given a report, you're talking to a collaborating physician, you're scheduling an induction, you talk to a charge nurse, you want to clearly chart the communication, you followed the chain of command properly, you really want to be overkilling. What did you talk about? Who did you talk to? Records were sent over, this was the history given, this is the plan of care. SBAR, situation background assessment recommendation, is a really helpful tool when you're charting. It's similar to a SOAP note, the situation objectives assessment plan. You want to have key acronyms that you're consistently using when you talk to EMS, when you talk to a collaborating physician, especially those transports, those fragile situations that you just don't know, is it something minor and it'll self-resolve, or does this a serious warning sign of a complication that really prompt communication and clear communication was really important. So you want to chart. I think a lot of times we see malpractice cases with bad outcomes where it's a transport during labor, it's something that was missed in assessment prenatally, and then it had some sequelae that caused a stillbirth, caused a bad outcome, caused an abruption, caused a very serious complication because the midwife wasn't practicing within their scope. They were giving recommendations that weren't fully part of their skill set and knowledge. They didn't take proactive extra assessment pieces, interventions, talk to the high risk providers, maybe transport in a timely manner to a new setting. There's a lot of things that if you don't document it, it's a lot of verbal he said, she said, and with juries, they tend to side with the traumatized mom and the baby poor outcomes. And so as a midwife, as a physician, as a hospital system, healthcare, if we talked about VBAC, we talked about all these options, and we recommended they go to the hospital setting because of XYZ in our assessment, and they're refusing, you want to quote exactly the words that were used in the decision making. It is hard in labor because there's a lot of emotions, there's a lot of trauma, there's a lot of fear. The woman's not cognitively in her own state of mind, so having her support team around, having shared decision making, not just with her, but also the family members, really helps with reducing the risk of litigation. So you don't ever want to criticize each other in medical records. You don't want to say the patient's non-compliant, the patient isn't doing what I'm telling them to do, she's ornery, she's hung up on me on the phone, the physician is rude. You don't want to add emotions because that doesn't matter, and it really just makes things look worse in court. And finger pointing, like this physician wouldn't talk to me on the phone, and then, well, okay, then you need to go up the next chain of command. What were you doing about that? You need to go to a hospitalist. You need to talk to the charge nurse. You just don't leave it at that and finger point, well, it's their fault because the patient wouldn't do what I asked them to do. And you want to be very careful of like pain perception. And if they say, it's nice to do the rating scale to say, okay, their pain's an 8 out of 10, a 4 out of 10, to say, okay, they say they're painful, but they appear comfortable. Maybe you could talk specifically, they're moving easily out of bed, they're independently going up to the bathroom, they're texting on their phone during a contraction. Those are objective things versus using your subjective criticism and your emotional input for how things are approached. You want to keep your opinions and biases out. I see this often with home births, so where someone has transported, they decided, you know what, I want a home birth, and at 28 weeks they transfer care. The physician puts all this stuff in their records. I told them how unsafe home birth is, and they chose this anyways, and I clearly told them if they leave my practice, I'm not taking care of them anymore. They're putting their baby and them in danger. Putting your own opinions and biases does not help your credibility if there's a lawsuit. The jury can figure out you had biases and maybe you didn't fully give them the respect and all the options and choices based on your own biases. So with substance abuse patients, especially as midwives, physicians, we see non-compliant, we see drug seeking, drunk, all these words that are very discriminating. We want to be objective. Patient stated they had this much to drink, they had taken no methadone, they had taken no substances, the drug tax, the urine screen shows XYZ. The what does the objective testing say versus they appear drunk, they appear drug seeker, they're complaining all the time, all they're doing is asking me for medications. You need to really be careful because we want to give high quality care. We want to have team approached. If we're making our clients and our patients feel like they can't trust us, they're going to be less likely to follow up with things. They're not going to bring up everything pertinent in their history you need to know, and that can cause poor outcomes. And you can be held accountable if your own biases and opinions made it so that the assessment wasn't complete because the patient was too afraid to tell you something. You have to be very careful that that can come back to you. So you want to document whether you are, this is your best friend, your sister, you have a trusting relationship, you've had 4 babies together. You always want to document as if somebody is going to look at this later. You're going to transfer, your boss is going to look at it, there's going to be a peer review, it's going to go to court later. How are you saying? You're to the point, you're synced, you're not telling a bunch of fluffy stories. I see so many midwives will put, we did this Bible speech, we did a prayer, we did all this stuff, and you can have that communication, but the whole point of a chart is to protect you, to give good communication if there's medical transport. This is a medical record, and you want to talk about your assessment, your plan, what was concerning, what was normal. They're progressing during labor as appropriate. There's a deviation in normal, there's scant bright red bleeding, there's large amount of bright red bleeding. You've done the routine intrauterine resuscitation measures. What do they include? You reposition. There's a prolapse cord. You immediately called EMS. Like during time sensitive emergency situations, they want to know thoroughly, and you're not going to pause in your interventions to chart. You're going to have your birth assistant, your team put some high level notes, time, what was it affiliated with? They fetal heart rate 160s. You're going to back chart afterwards, and you're going to note in it, this is delayed charting due to giving emergency interventions and care. Especially in an out-of-hospital setting, we don't have 5 people in a call room. We can just all of a sudden ask for additional support. You're going to want your 2 staff, potentially 3 in a birth center in the home setting, to be focusing on care, focusing on getting additional support with EMS, doing quick interventions that are high priority, and quickly determining what are the intervention steps you need to do and what was the response you got from it. So look at your documentation as a protection for you of your license, your business, the other clients you're going to serve in the future, your personal assets. You need to look at your documentation as a legal leg to stand on if you ever get sued. It's your protection. So you need to overkill the documentation. That's why EHR systems versus paper charting is a little bit easier because you got a lot of clicks, and you can customize scripts and summaries versus you have to handwrite everything, and you get tired and you get exhausted, you miss things. There is a perception with EHRs and well-organized documentation that you're more likely to give good patient care, and that you're an organized person, whether it's right or wrong. Midwifery advice on avoiding lawsuits. There's tips you can do to help keep yourself out of court. We have a huge advantage as midwives taking care of our clients. We tend to get a great relationship. We see them the entire time. It's not a large team. They really get to know us. We go in their home setting. They're much more vulnerable. It's far less likely for community-based small private practice midwives to get sued. But if you're a nurse midwife, a large hospital organization, and there's many steps to the process and you don't have that relationship, it's not as much of an advantage to you. The biggest things you can get sued for is negligence, and that's the failure to exercise the degree of care that an ordinary person with due diligence would have done in the same situation. So if there are assessment pieces you're missing, or you've done a thorough assessment and something happened, it's very different. They can't call you negligent if you didn't know this. You didn't have any risk factors to make XYZ happen. On a placenta abruption, if there was no warning and no risk factors for you to be emergent on care with, it's very different than someone that in a same situation, if they've had 3 prior C-sections, the national standard and other midwives based on national scope and training would have not taken that patient as a home birth client. So you have to compare yourself. What are the decision making you're doing for scope of practice, who you're accepting, what your policies are saying, assessments throughout pregnancy. Are you offering prenatal panels? Are you offering a 20-week anatomy scan? Are you doing the discussion at 28 weeks gestation? You know their blood type. Are they Rh negative? Are you doing the same standard of care discussion, not saying you have to give it to them, that someone else in routine prenatal care would be offering? And especially those traumatic experiences, the morbidity and mortality where the mom and baby have some complications and there's death involved, they're going to look really closely at every step of your care from the very first visit all the way during labor, all the way to postpartum, whatever you had done during the process, to see if there was anything that could have been different based on an assessment, questions that were asked. And your documentation is that defense. So malpractice gets more and more restrictive. It's more of a violation of the professional duty, and it's a very unique kind of negligence. Are you failing to meet the standards of care in a birth center standard, home standard, hospital standard, your collaborating relationship, your hospital privileges? Are you following the guidelines and recommendations and protocols and evidence that's currently in place? And would other people, that's why they have legal expert witnesses that'll say, yep, they followed everything they were supposed to, this was just a bad outcome, or nope, other providers in similar situation would have assessed for this, would have asked these questions, would have done extra testing, would have transferred sooner. You have to be very careful to avoid litigation by using just caution, common sense, maintaining a heightened awareness that OB obstetrics, unfortunately, is a high-risk liability platform. I've seen too many midwives, their practices were successful for 10, 15 years, and then it was just one outcome. Even though they'd practiced this way the whole time, they're really being held to a negligent standard because this one time wasn't a near miss, it caused a bad outcome. The standard of care that they're offering is negligent, is part of that discriminatory level that other practitioners with similar skill sets and scope of practice are not doing. So you want to know your strengths and your weaknesses. And if you have weaknesses, you either don't offer that service, you're more cautious with your assessment, your resources you know around you, and you know your strengths. If you've done breech deliveries before and you've got a certification, that's very different than someone that's like, I've never been trained in it. She knew ahead of time that the baby was breech, and I told her that I have the skills and expertise to do it. And then there was complications because you didn't have the skills and expertise to handle a certain procedure situation. Being accountable to refuse an assignment, to refuse taking care of a patient. You've got a team approach, you've got a client you're thinking about taking, she had some birth trauma, you emotionally think it's terrible what happened to her, but she's not a good candidate for a midwife, an out-of-hospital birth. You're coming on shift, there's severe shortages, and you're knowing the safety. If you do not stand up and follow the proper chain of command, you're held accountable for the responsibilities of that unit, of the care that's being done, because you did not stand up and follow the proper chain. We're too short on nurses. We can't have this many people laboring on a unit. We've got a VBAC. The OB should be in-house. Anesthesia should be in-house. We should be clearly advocating for policy improvements, policy accountability, and taking good patients based on our scope and resources we have within our practice set. You want to delegate safely. You want to delegate to a birth assistant, someone that has the skills and training. If you're delegating to a birth assistant, hey, I want you to go to her house first, I want you to check her cervix, I want you to do heart tones, and she's never done that before, or she's not a midwife student, and even like it's a really gray zone. If you're delegating things that are exclusively the role of a midwife, it doesn't matter if they have experience in it or not. You should, especially in the out-of-hospital setting, you want to be the first one there. You want to be the assessment. The scope for an assistant is delegated emergency situations, labor support, support breastfeeding, helping with documentation, you want to clearly know the role and responsibility of each person on your team, what skills they have, what competency checklists you've done to confirm that they have those skills. And that's why it's really important for your staff to have good trainings, the good policies, good handoff tools, clearly defined job descriptions of what's included, what's not included, if there's additional skills, how are they getting them, is there certifications, is there one-on-one trainings, are there signed off competencies being visualized. You want to get clear and concise orders and expectations. You want to read them back to someone. You want to, if the phone's cutting out, you put an order in the system and it doesn't appear right, you want to, maybe someone has been ordered a medication and they have an allergy to it. You don't just give the medication, you want clarity, you want to understand, because a lot of times mistakes just happen, they put it under the wrong patient. So any high risk medications, any high risk situation, you never want to practice outside your scope. Midwives sometimes in the hospital setting get put in tough situations. The OB at nighttime, for example, the CNMs don't have privileges to take care of C-section patients, to do the postpartum recovery. It's not part of their privileges at the hospital. And the doctor will call and be like, it's 2 in the morning. Can you just put in this order for me? Can you do XYZ for me? The midwives have to stand up for their scope, their privileges, their delegation rights that they have in a facility, they have with a practice, because as soon as, even if it seems minor, like Tylenol, Motrin, maybe it was a contraindication to the Toradol, to some of the medications they're getting by anesthesia, and you're responsible. One, it wasn't part of your hospital privilege delegation, and two, any of the care and that ripple effect you're responsible for. So you have to clearly understand your privileges, your guidelines, your scope of practice. If there's medications you're not familiar with and someone is asking you to order it, you need to ask for clarification, because some of them sound very similar, and if you order it online and you think you're ordering the one that they wanted, you may be ordering a blood thinner versus a asthma medication versus a pain medication, and they have completely different effectiveness, complications. So anytime you're not understanding an order, you can't hear them clearly, you should always be repeating things back in an emergency situation. The nurses and providers during a hospital setting are really, really good at that. And even midwives and birth assistants, having good, clear communication at the bedside with the. So you want to really stress, anytime you don't understand, you didn't understand the wording, you didn't understand the dosage, you didn't understand the route, you didn't understand the prioritization of what you should be doing, just take 5 to 10 seconds to pause. It makes a huge, huge difference of safety and standards and expectations. Because if a nurse runs out of a room and thought she heard one medication, she goes to the med pyxis, she gets something else, you've just wasted 5 to 7 minutes of an essential situation. You want to make clarity and clear communication if something is needed. If you're calling on the call light and the secretary in the unit doesn't really hear well, you need to have very clear communication. I can't understand what you want me to call, because if you want a code called overhead and they call the wrong code, you can have a ripple effect of poor complications. You want to make sure you're particularly careful with medications, with interventions that have a high risk if they're not done properly. The 5 rights for medication administration: you're doing the right patient, the right drug, the right dosage, the right route, the right time. A lot of the EHR systems and scanning will help with decreasing that error and mistake. In the community-based setting, you don't have as many of those check and balance systems, so you need to be the one that is double checking. You're having a couple of people look at it, double checking the name, the expiration, the amount, the dosage, the route. There's no allergies, there's no contraindications to be giving that. You want to stay on the patient's good side. You don't want to be rude. You want to continue communication with the patient the best you can. Lawyers obviously going to give you different perspective advice, but relationships are huge. A lot of times people sue because they want answers, and the lawyer will promise them they'll get answers and they'll get money. If there is complications, sometimes clients don't want to sue, but they have to figure out how to pay these medical bills. And if you have malpractice insurance or your organization is the deep pocket, many times clients and patients will be looking for answers to mistakes, to clarification on policies, to really communicating clearly some of these sensitive situations. So never ever offer opinions, always stay with the facts, the evidence, if quotes of wording was said by a client, by a situation, a decision was made, you want to give a clear picture objectively of what is going on. Never sign any consent, any agreement, anything you don't understand. I see too many times midwives, providers will just sign an agreement, a consent, a refusal form, but they had never actually read it themselves either. And even if you're saying as the witness, I witnessed the signature, you need to make sure you and the person signing fully understands the paperwork, no matter how big or small it is. Stick to the facts, stick to the assessment, the situation, the background, what you did about it, the follow-up, the communication you had, the step-by-step, tell a detailed, objective story of what is happening so that when it's looked at in court months or even years later, it tells factual, accurate, complete, and timeliness. You followed up with things based on a reasonable human being can do. You followed the step-by-step guidelines that if someone else was taking care of that person in the same situation, you did the best you could with the resources and the information you had at that time. Do the right thing always. Try to not choose a procedure, a test without informed consent, without convenience. Try to keep our biases out. Use equipment that's been sterilized, that's up to date, it's met quality measures. If there's any problems or issues with equipment, you're quickly changing it out. Your standard of care is as high as it possibly can be. In the hospital setting, particularly on med-surg and neurology units, you don't want to use restraints unless it's an absolute last resort. In OB, it's not as big of a deal. We want to prevent falls as much as possible. This seems kind of silly in maternity, but they're laboring, it's dark, you want to pick things up off the floor. The last thing we want is like an abruption or a complication because they slipped and fell in some water, they bumped their head because they were unstable, they were given some medication, they went up to the bathroom and nobody helped them. So fall risks on any unit are really important to follow up on and protect against. You want to be familiar with advanced directives. Whenever it's kind of harder in the community-based setting, but in the hospital setting, you want to know, are they a do not resuscitation? Are they a full code? Are they a partial code? It doesn't matter if they're 19 or 90. You don't ever want to make assumptions of maybe this person does want to be ventilated. Maybe this person doesn't want blood products. Maybe this person, what are their personal beliefs and viewpoints? If they can't make their own wishes, who in writing are going to make the wishes for them, or what specific aspects of their decision making they would like to have in writing their preferences ahead of time. Doesn't matter if you're a healthy person, this is something important for midwives to have a discussion, to get proactive with living wills, with the durable power of attorney. We want to make sure that the patient, this is good, they're growing a family, they're, heaven forbid something happens to them and they can't make their own decisions, they get in a car accident, we really need to help advocate for them. Whether you're doing a private practice or a hospital, you want to follow the policies and protocols of that organization. If you're going outside of the policies and protocols, is there new guideline changes? We need to get the policies updated. The patient had requested alternative therapies. You need to document really well why you went outside the recommended policies and procedures of the organization. You want to create a safe working environment, and that includes proper training, adequate staff, the equipment's working well, you've had good conversations with the clients, if it's dimmed in the room, there's not cords on the floor, you're picking things up, you're making sure that everything, especially with water bursts, you're not putting electrical things next to the water. You want to create a safe environment because little things may turn out to be big things that you don't even. So what to do if you're being sued? You know, it's hard. We make mistakes, whether you're in midwifery and nursing practice. Many of us don't even worry about a lawsuit, especially in community-based. They're like, my clients love me. I only serve 2 clients a month. It's so rare. We serve the Amish. The Amish don't sue. Whatever stereotypes and myths and misunderstandings you want to tell yourself, it's rare to be sued, but when you get sued, having documentation, having the proper quality measures, protocols, training, conversations with the patients, and documentation of all these things are essential. They're absolutely essential. Because even if you're serving the Amish, you transport to the hospital everybody in the step. It's not just the patients that can sue. The hospital can sue. They can have a report against your license. You want to make sure you're always giving the quality of care that's best possible within your scope of practice. So you need to know your state regulations. You need to know your certifications, your scope, your standards of your local area to make sure you're following everything. Once you're done with all that and the patient is taken care of, those near misses, that serious situation, you can have a lot of fears and trauma and anxiety about lawsuits. And the best way to minimize a lawsuit is to have a touch base, be proactive with your manager, putting incident reports in, talking to your legal team, being proactive that this was a near miss that I'm worried might end up in a lawsuit. Sometimes the lawyers will give you advice to have a conversation, good follow-up with the clients, and respectful resolution of the outcomes and step-by-step plan that was occurred. You really want to make sure you're being proactive. Anytime you think that there may be a potential lawsuit, a near miss, a complication, it helps a lot to be proactive versus reactive. So your charting, your conversation with clients, your legal team, your malpractice insurance, what does it cover, what does it not cover, are your policies and protocols up to date? Use this as a learning opportunity. So just as a conclusion, there's a lot of legal defense measures that are extremely important for midwives and their organizations. We want to stress that your documentation is honestly your single best defense in court later in the future. So you want to stress everything you do, your education, your questions you asked, the emotions in the room, the specific interventions, the follow through. Did you assess things and take care of that in an appropriate, timely manner? You want to keep the biases out. You want it clear. You want it to the point. Depending if you're paper charting or EHR systems, you want to really be thorough and consistent. You want to be real-time charting as much as you possibly can. Obviously, in emergency situations, you're going to take care of the care. You're going to have your assistant put little high-level notes of the times and interventions done. Your charting is literally your legal defense for many, many years to come, because you're not going to remember things. And if the bare bones is charted or it just doesn't look good because you missed things, even though you forgot to chart it, if it's not charted, it's not